Hi, listeners.
Hello. Welcome to the Med Insights Unleashed podcast.
With your hosts,
Z.
and John.
Hi, John. How's it going? How are you?
Hi, Zara. Going really great. Had a fantastic weekend. Working hard on Med Insights Unleashed. Couldn't feel better.
Awesome. And today we are very excited because we have Professor Vogel back into the recording studio. And John, what's on the docket? What's on the topic for today?
Yes, Professor Vogel is talking about a hot topic, which is covering the challenges that physicians and patients have with access to treatment. And he's focused on the differences between Germany and Canada.
I am very biased here because Professor Vogel is now in Canada. He used to live in Germany, but I think you still go back and forth between Germany and Princess Margaret Hospital in Toronto. So, can you please share with our listeners your experience thus far, your move from Hanover, Germany to Toronto, Canada, how that came about, why did it come about, and some of your interesting experiences that you've had in Canada and challenges, because I know our Canadian healthcare system is challenging.
First of all, thank you very much for having me on your podcast. And as you said, indeed, I'm a hepatologist by training. I went to med school in Germany, and then the first 25 years of my life as a physician, I also worked in Hanover in Germany. So I really had the privilege really to experience all the different advantages and disadvantages the German health system provides. And some of the advantages I took for granted, to be honest, and thought that would be just the way it is. And some of them I do appreciate now far more because I learned a little bit the hard way that not everything that we did in Germany is also available here. I mean, Hanover was great.
And what is your current appointment in Toronto?
I have a joint appointment at Princess Margaret Cancer Center and Toronto General Hospital. So I think it's a great place to be. I mean, Toronto is a amazing city. Um, I really like the Canadian lifestyle, and the two hospitals offer so much. Yeah. So we have so much like research going on, basic science, core facilities. So it's exciting to be here. But as a physician, of course, it also comes with some surprises, I would say. Not everything is available here in Canada, what was available in Germany.
You sound very happy in Toronto, and the new hospital sounds very exciting. But there seems to be a couple of surprises. Can you tell us a little bit more about those?
Yeah, I mean, again, it's not all black and white, right? And there are some advantages, some disadvantages. And starting maybe with the advantages, my focus is liver cancer. And here in Toronto, we do have the Toronto criteria have been established for liver transplantation for liver cancer. And these are the widest criteria that have been ever employed to select patients for liver transplantation. Yeah. So it's really a great opportunity for patients here in Toronto, which we do not have at all in Germany. In Germany, we have, I think, the most strictest criteria for liver transplantation for patients with HTC, which is really awful because I think we are not providing state of the art care, and there are a lot of patients that could get a potentially curative treatment which they do not get.
Which criteria does Germany utilize?
We are still utilizing the criteria that have been developed by an Italian colleague, Mazzaferro, the so-called Milan criteria, which means a patient that have a limited size of tumors. It's very, very restricted. I think we have multiple data showing that they are far too restricted. And importantly, we have now options for downsizing and downstaging, and these patients have an excellent outcome. I think the German system has not adapted to these new developments. Yeah. But it's different when we think about systemic therapies. Yeah. And this is something really which really surprised me a lot because I know that, I mean, there are different health systems also within Europe. And I do understand that approval by FDA and EMA does not guarantee immediate access. Yeah, but I would expect that it comes eventually.
What is it like in Canada?
But the health system here in Canada is so unbelievable restrictive and really not offering many important therapies to our patients. Yeah, I'm just talking for GI cancers, yeah, and liver cancer. My focused perspective on treatment of specifically liver cancer. Yeah, but in liver cancer we have seen a lot of developments recently. Yeah, and it's interestingly that here the approval and more importantly the reimbursement is driven by the old criteria that you need a phase 3 study, proven survival benefit. And if you have and can provide that, you get eventually like approval and reimbursement. Yeah. But specifically in cholangiocarcinoma, we're talking about a very rare tumor in which we know that there are a lot of genetic alterations for which we have targeted therapies available. However, this is mainly phase 2 evidence, which means we only have at least prospective data, but only single arm data. And you could always argue, I mean, we don't know whether it's prognostic, predictive, or a true treatment benefit.
If there is a true benefit, are these drugs being approved in other countries?
I think for many of these therapies, we've seen approval by FDA and EMA. And I mean, at least in Europe, most countries have, and also globally, not only have approved the treatment, but also reimbursed treatment. But some of these treatments are not at all available here in Toronto. And I think that's really a problem for our patients here.
On the financial toxicity, when we're developing very costly randomized phase 3 trial to show that you had a survival benefit over standard of care, but you also had to provide a pharmacoeconomic argument to actually show that there was a financial benefit. So do you think that this is making it harder, or does it make it easier? Does it support you in your arguments to the government to get these approvals? How does that relate?
Yeah,
On the
yeah, right. And I mean, for some treatment, we have evidence, but the survival improvement of median 6 weeks. So is that meaningful? Is that not meaningful? I don't know. It's a very tough decision. I personally think it is meaningful, even if it sounds really not like a lot. But I think this is what we have in the last 10, 20 years, that the overall benefit is usually moderate, but in the end, it adds up, right? And I mean, if you take colon cancer, where we had trials where we had only very limited survival benefit, I mean, median overall survival is now approaching 3 years and more, right? So I think having more options, having more drugs available, eventually improves outcome, right?
Can you further expand on cholangiocarcinoma?
It's a very rare tumor. We know that there are some genetic alterations which occur in up to 5 to 10% of cases. And one example which we are debating a lot at the moment, and maybe you can follow my Twitter tweets, you will see, are treatment of FGFR2 fusion. Yeah, they occur in around 10% of cases. And we have a couple of drugs that have been tested in this setting. And these drugs have shown very consistent efficacy data. We have response rates of 20 to up to 60%. We have disease control rates of 80% and more. And for progression-free survival in second and third line of 8-9 months. So it's a very consistent picture of efficacy in a very deadly disease with a very dismal prognosis of a median overall survival of only around 13 to 14 months.
Have we seen approvals in other countries with phase 2 data?
We have seen, even with these, even though we only have phase 2 evidence, we do have seen approvals by FDA and EMA. And if you look in Europe, I think even almost all countries have approved pemigatinib, which is one of the first FGFR inhibitor, which have been tested in this setting. Yeah, and I think there are only 1 or 2 countries in Europe which do not yet reimburse, but most of them have done it. With that, it sounds like that the majority, if not all, health experts agree that there's efficacy. Yeah. Still, here in Canada, we just got an assessment by Cardiff, and specifically here in Ontario, for the efficacy of pemigatinib, and they stated they do not see the evidence because it's only a phase 2 study. For me, it's unethical stating something like that. Of course, I agree with the point that in general, we do need phase 3 evidence, and we do need and should perform randomized trials. But we also need to accept that when we are talking about really rare tumors with
Right.
rare alteration, it's simply not feasible. And then I think it's not ethical to withhold these treatments. Yeah. And we have sent so many letters, and I really feel bad for my Canadian colleague that have experienced this the last 3-4 years. Yeah. And again and again and again outlining the data. Yeah. And there's nothing.
So do you think that in addition to the physician advocacy that yourself and your other Canadian colleagues are trying to drive, do you think that there should be perhaps an additional component of patient advocacy? To your point, you have cholangiocarcinoma, it's rare disease, but yet you have solid phase 2 consistent data, yet the reimbursement bodies refuse to cover the drug. Is it time that more patients stand behind it?
I mean, I think it should not be like this. Yeah. I mean, I agree with you that here in Ontario, and I mean, we have to also state that Quebec is one of the first provinces that does reimburse the treatment. It took also forever, but at least they're doing it now. So even here in Canada, it's not an agreement on whether or
Right.
not it should be reimbursed, which also, I mean, leaves you with some question marks, right? Maybe we do need patient advocacy group now to really push Cardiff and the reimbursement agency, as you said, here in Ontario and the other provinces to finally reimburse these drugs, right? But I'm not always convinced that everything with positive data needs to be reimbursed. And I think we really need to discuss wisely what is really the impact, and can we do better? Are the data enough? But for the FGFR inhibitors, it's so consistent, so clear the picture. Yeah. So that I think this should be approved and reimbursed without the help of any patient involvement. This should just be approved.
What I've learned being in Canada over the many years is that by the time drugs are approved by FDA and they're approved by EMA, Health Canada, there is a significant lag time. So you have approval of the drug by Health Canada, and then there's another component of reimbursement. And reimbursement does vary depending on what province you live in, as you've just highlighted. I think there needs to be a speedier process. Cancer doesn't wait. So why do patients need to wait for treatment?
Yeah, I agree. But actually, it's beyond Canada, right? I think we can always argue about like financial toxicity, and also the question, how much does a country invest in healthcare? And so what are, for example, the costs for health insurance? Is health insurance provided to all patients? How much does everybody is paying for the health insurance? And probably there are also significant differences, right? And if all individuals do not pay like a certain amount, of course, there's only a limited amount available in the system, and you need to decide how you invest this money. So it's not only a question about demanding that we want to get more. Of course, we also need to pay more. I mean, this is, of course, the bad side. Our rates for health insurance in Germany are quite high, but I understand that I also get something back when I'm sick. You need to be willing to invest in that, and you need to be willing to pay for something, even if you are not sick, right? Which is sometimes difficult. Yeah. And not really the message as a politician you want to tell your voters, I guess. Yet now you need to pay another whatever 100 whatever bucks per month for your health insurance. I mean, it's not a fun story, but in the end, it comes
You
back to the
get
question. So how much do you pay, and what can you expect to get back? And I mean, you need to invest a certain amount to get something back.
In your mind, what is financial toxicity?
I mean, financial toxicity is a different question, and I understand if you make the statement that we do not have enough money to pay for that, then it's a fair conclusion. And you can say, okay, if it's about the money, we need to decide, can we get more money? Can we ask for more money? So does everybody pay a bigger share? And then we could openly discuss it, and then we can decide how much are we willing to 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 give into the system from our money, right? And so is it about financial toxicity? Then we can discuss that, and we can decide what amount are we willing to pay in order that we get the best possible treatment. Yeah.
Yeah.
And if we agree that we are not willing to pay a certain amount or more than a certain amount, then we also need to accept that we don't get everything that is available, right? But the other point is that if we are just saying, as coming back to the FGFR stating, we do not see the evidence, right? This is nothing, because I mean, everybody can see the data, everybody can see the consistency of the data, and you can't just say, I don't see the evidence, right? I mean, this is not fair, this is unethical, and this does not really help us, right? So and therefore, I think we need to come up with processes, and this is not a Canadian problem, but a general problem. How do we define benefit? If we accept that these phase 3 approaches are no longer, or at least in some situations, not feasible, because we are talking about small group of patients, right? Like rare cancers with even rare alteration, in a setting where it's just impossible to conduct phase 3 trials with 1,000 patients. Yeah, we cannot do that. We need to have a different approach. Yeah, and so we need to come up with criteria to define benefit in the absence of large phase 3 studies.
Can you tell us a little bit more about the reimbursement in Europe, because it's different to the rest of the world?
Even in Europe, the time to reimbursement varies dramatically between the different countries. Yeah. So I had the luck to be in Germany, and we always, when we have a phase 3 trial available, we were able to use the drugs, but we also pay a lot for our healthcare insurance, right? So
Same in
yeah,
Australia.
and in other countries it takes like 2-3 years. Yeah, again, this is too long, and then again we need to name the problem. Is it really the absence of evidence, or is it financial toxicity? This needs to be separated. Yeah, and if it's not about money, we should have similar criteria and should allow that the drugs are basically in a similar way available to all patients. Yeah.
The question is, now you've got a patient sitting in front of you, right? And we have situations here, even globally, but in the US, where if a patient and it's life-threatening needs therapy, that they actually even travel to another state to get that therapy. So is that permissible in Canada? If you've got a patient with cholangiocarcinoma sitting in front of you, which is rare, as you already said, but can they get treatment in Quebec?
Yeah, of course. There are different criteria on how and at which point in time you get a drug. If you're moving from Ontario to Quebec, I think it's not immediately. You need to live in a state or in a province for a couple of months. And I mean, going to the US to buy the drug there is, I think that can't be. It's a first world country, right? And this should not be like this, right? And I mean, for me as a physician, I really feel bad if I do have like patients with FGFR2 fusions in cholangiocarcinoma. These are often younger patients, female patients. And if I'm sitting in front of these patients, it really feels bad knowing that they are drugs, right? And not being able to not even talk about them and not be able to prescribe them. Patients are doing their own research.
They're not stupid.
They do know about these drugs and treatments, and they ask me, so why can't I get it? Yeah, what can I say? Because it's not reimbursed here.
So then it comes back to my earlier question. There ought to be a component of patient advocacy where patients need to go to their local, representatives, their politicians, and say, look, this is a life-saving potential option that we're not being provided and we ought to be provided. I think there needs to be that patient advocacy component behind it to help drive change.
Maybe, Zara, that's where MedInsights Unleashed comes in to stimulate that conversation and get the advocacy going.
Absolutely. I think it's a really great point, John. Any last any last comments or suggestions that you wish to put forward?
No, I think it's what I said in the beginning. It's definitely not black and white. It's not all bad or all good in either system. I think all the systems have their pros and cons, and there are a couple of things which we could also improve in Europe, in Germany, and wherever you are. Yeah, so I think we do not yet have the perfect health system in any state. Yeah, but I think we do have opportunities, and in terms of reimbursement, we probably need to be a little bit more open, a little bit faster here in Canada, because I think that at the moment it's really a difficult situation, to be honest.
I just want to really thank Professor Vogel, as always, for his clear insights and his outspoken words for the patient. I think this is where MedInsights Unleashed comes to play, and we need more people to become vocal about ensuring that they're getting the right treatment for the right cases at the right time. And Professor Vogel has just brought to light, the patient with cholangiocarcinoma. The Canadian people need to become significant advocates on behalf of their doctors and their own treatment.
Absolutely. Yeah. Well, thank you, Professor Vogel. And John, as always, thank you for our time together. And we will plan our next episode. Hopefully, Professor Vogel will return so that he can discuss the Emerald One study in adjuvant in the intermediate stage for liver cancer.
Very good. Thank you very
Thank
much
you.
for inviting me.
Ciao.
Thank you. Ciao.
Bye bye.
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.